Good morning and welcome to our monthly live broadcast of Peripheral Cases from Mount Sinai Hospital here in New York City. I'm your host Vishal Kapoor here, bringing along with Dr. Christian and his team for another exciting live case. Before we go on to our cath lab, I just wanted to let you know that our live cases and the cases from the past are available on our website, CCCLiveCases.org. Under the Peripheral Interventions tab, you can see our previous cases, our discussions, questions, concerns, and comments there as well. Also, just to give you a heads up, our annual New York Endovascular Summit is scheduled for this September from 22nd to the 24th. The details of the agenda are up on the website at nybebs.org. Kindly visit the website and you'll see an entire spectrum involving the Endovascular Summit, the Podiatry Summit, the Fellows Course, the Aortic, and the Venous Summit as well. So we'll be more than happy to have you here in New York in a beautiful weather and a time during the fall to visit our place, see some cases, talk to the experts, and then have an educative interactive session. So without further ado, good morning, PK and the team.
Well, good morning, everyone. It's a real pleasure to have you here for this very exciting live case. Want to really welcome everyone to the summer, I guess, and really getting excited for NYEVS. As Vishal said, as Dr. Kapoor said, this year is really going to be exciting because it's our second year of doing the course as a combined group, and we're working on a lot of different nuances, a lot of different changes. Dr. Rao, Dr. Han, Dr. Tadros, Dr. Ferries, and their team have worked really hard at developing a really robust, put the IVUS on, robust aortic program. So that's going to be really, really exciting for us this year because, I know that it was met with a lot of, enthusiasm last year. And I think we've learned a lot because, of course, we could always do things better. And I think we've made some important changes to that with simulation, cadavers, and some great lectures and case presentations. The most important thing for the fellows and the residents watching, vascular residents, is that, we have these case competitions that we're doing that we're very excited about because we really want the younger people to get really excited about vascular, and academic vascular is what's our passion. So what we've been able to do is partner with our industry partners and really be able to provide a robust forum for discussion. And the discussion, is going to be graded because I think that's what's part of the fun, the competition. And we're going to be able to give out some really nice prizes to our fellows, which are obviously useful for your academic career. Nothing really, we're going to say social, but a lot of fun. So that's one thing we're excited about. And then we also have a lot of these discussions with what's called as, case expert discussion, pimp the experts, a lot of different forums where there's a lot of interaction. So anyway, with that brief introduction, I want to introduce our team. To my right is Dr. Karthik Guja, who's our assistant director here. To his right, just standing next to him, adjacent, is Dr. Rao, who's here again with us because I think his input has made our program so much better in terms of the education that we're able to provide in a multidisciplinary manner. So thank you, Ajit. In front of Dr. Rao is our graduating fellow who's in his last day of cases, or second to last with me, and then he's got tomorrow with Dr. Kapoor and then Friday with Dr. Sharma. So the cases, so that's Dr. Ibrahim Ali. To my left is Ray Lascano and Elizabeth, our lead nurse, as well as we've got Damien, our lead tech. I think Raman just arrived, so I can hear him. So welcome, Raman. So we got a great case for you guys. So without further ado, we're going to have Ibrahim present the case, and then we're going to get started.
All right. Good morning, everyone. So we have a 52-year-old female presenting to us with a chief complaint of left lower extremity pain at rest. She had Rutherford class 3 claudication for about 2 years, has been treated medically and doing well. You could see her medical therapy down below, but over the past month has slowly started to develop into rest pain and actually presented to us with a physical exam that I'll show you on the next slide. She has a past medical history of GERD, hypertension, hyperlipidemia, and hypothyroidism. Her medications include insulin, amlodipine, aspirin, losartan, atorvastatin, Zetia, and Xarelto 2.5, which was started recently, as well as Synthroid. former smoker, and you can see the ABIs there are pretty severely reduced. She did have an arterial duplex before some of the other non-invasive studies, and it did show diffuse monophasic wave patterns in the common femoral artery as well as the SFA. Moving on, this is her physical exam. You can see that she does have some discoloration of that left toe. Whether it's related to emboli or ischemia is still hard to tell, but this is kind of the physical exam that we are presented with, and she only has very, very weak, maybe monophasic wave patterns in the DP and the PT bilaterally. So the next step that we did was we did a CT scan. Just to see what the inflow was like, because there was no real disease seen on the ultrasound, just monophasic wave patterns. So this is a run through the CT, and I'll have some still images as well, and I'll let it play again. But coming from the infrarenal aorta down, you can see that the infrarenal aorta is not very diseased, but as you get further and further right before the bifurcation of the iliacs, you'll notice a stenosis, and it'll replay right now. Again, that proximal or infrarenal aorta now starting to get disease, and then there's a tight stenosis right here before it separates out into bilateral iliacs. And this is another view of it, just so you can get a better understanding. That distal aortic occlusion and relatively patent iliacs. Now, measuring the infrarenal aorta, you can see both kidneys at the side, so this is just below the kidney level. We have a measurement of 1.2 and 1.3 centimeters. As you go a little bit further into the abdominal aorta, in the distal abdominal aorta, you can see that the measurement gets a little bit smaller and the vessel tapers down to about a 1.1 centimeter vessel. And this is a close-up of our actual lesion. You can see that it is heavily calcified stenotic with a little bit of thrombus as well. And then this is an angiogram, and we'll show you a further angiogram as well. And so initially we were thinking about getting radial access. We ended up going bilateral groin access. Her left radial was actually closed from a prior coronary cath. And our plan right now is to do the distal aorta, and we'll discuss that a little bit more. And if needed, we can extend out into the iliacs. Okay. I'm going to give 2 people. So our discussion points for this case really, it's quite vast, and I don't think there's a lot of information out there for us to guide us exactly what we should be doing, but there are many options. There's obviously a CRAB technique. We could just do a focal distal aortic stent.
Ring down.
Some people have done EVARs as well. Then obviously our discussion will go into whether we need a self-expanding stent or a balloon expanding stent in this area, a covered stent, how we size those stents, the involvement of the IMA and the lumbar collaterals, and how we have to be cautious of that as we're placing covered stents, the role of IVUS and debulking therapy with IVL, and then we'll talk about long-term medical therapy and long-term patency. But those are our discussion points for the case.
Great, thank you very much. Rich, can you switch this microphone to Dr. Rao from Ibrahim? Unfortunately, our technical team does not have enough microphones today, so we had to share microphones. So I'm doing our IVUS for whatever reason is not working, Vishal and Raman. So what we're doing is we're doing an IVUS. I know you can't see it.
Right.
Unfortunately, it's not working. I'm just trying to characterize the lesion. So a couple of things. Any questions from you guys before I ask Ajit questions?
Can we see the angiogram you took today? I know these are good angiograms. Let's see the angiograms and the accesses you have, and the runoff if possible.
The runoff has 3 vessels. Actually, he didn't show it, but we have 3 vessel runoff. And here's the angiogram today.
Wow.
Can you turn the camera towards the IVUS so I can show them the IVUS? Can this Medinbox camera switch and look at the IVUS over there? Yeah, turn that camera towards the IVUS because the IVUS is right there.
Yeah, so that significant distal aorta can definitely explain the significant decrease in bilateral ABIs like 0.6 and 0.5 in this case. Exactly.
Nice, so there's the IVUS right there. So I'm going to do another run. So let's go live again.
Piggy, you have your IVUS on the left side or right side?
We just put a 4 French left to show you the pressure gradient, which is massive. But I upgraded to a 5/6 slender because of the IVUS. And you can see here that the IVUS I'm at the aorta proximal to the lesion, and I'm just pulling back. And as maybe Ajit can comment because he does a lot more aortic IVUSs than we do.
Yeah, sure.
What do you think, Ajit, so far? Anything you see in the IVUS there?
Definitely see
calcium.
I would say I see some calcium, but overall, no, the lumen looks okay. But as we keep going down, things I'm looking for are like where obviously the stenosis starts, how calcified it is. And so you can see right here, it gets very, very narrow. It's almost nearly occlusive. I would say there's calcium almost circumferentially.
A mural thrombus there?
Yeah, and then even, some little soft plaque versus some thrombus there. Looking at that toe, I was a little worried about embolus, so this could potentially explain that too.
And the rest of it looks okay.
And then the rest of it distally looks good.
Okay. So Ajit, when you look at these CAT scans, what like for the audience at home, what are you looking for? Like when you look at a CAT, I know obviously calcium. What great vessels are you worried about? What relationships are you worried about in terms of how you approach this? Because as Ibrahim said, there are many ways of taking care of this, right?
Yeah.
From an aortic stent graft all the way down to just a covered stent in the aorta, maybe even a bare metal stent in the aorta.
Yeah, no, great question. So I think number one is just where exactly it is. So both in relationship to the aortic bifurcation and then also to the IMA. So in these occlusive cases, if you can, you don't want to burn any bridges. So I think preserving the IMA, which can serve as a important collateral. And if you see any other big lumbers, if you can, I think that's ideal. And then obviously close to the, how close it is to the aortic bifurcation, because, one of the things that we worry about is, of course, a rupture. And so you want to make sure you have enough seal above and below. So that way, if you do disrupt the aorta, you're not in a bad situation. So in this lesion, I thought we had enough room above the aortic bifurcation to potentially seal based on that angiogram and also the CAT scan. And then, of course, the last thing I would say is probably the calcium. So, there's obviously some adjuncts like shockwave and things like that you can consider in heavily calcified aortas to help kind of crack the calcium so the stent opens up well and potentially disrupt, don't disrupt the aorta.
So when you look at this now, so covered stent versus bare metal, is calcium, because back in the day, we always used to use bare metal. The old cordis stents, we used to crimp them on and just put them up, put them in that area.
That sounds terrifying.
It was terrifying, off the old balloon angioplasty. But in today's modern day, are these always a covered stent case, or is there times when you do a bare metal?
I would say for me, most of the time I use covered stents. When we're doing EVARs, things like that, we're most of the time we're using covered stents, and I think one of the advantages is if it can prevent rupture, so you can seal right away. Especially in these calcified lesions, I think a covered stent is always the way to go because those are high-risk lesions. I suppose in a lesion that had soft plaque and not much calcium, you can consider a bare metal, and you might be able to do that without disrupting anything. But I see a little disadvantage with these lower-profile stent grafts, to just put in a covered stent most of the time.
And talk us through. Maybe Karthik, you can answer this one, or maybe Raman and Vishal, you guys can talk about while we're just changing out wires here. When you would do a CRAB, when you would involve the iliacs, when you wouldn't. Is there a reason to do it with minimally obstructive disease versus just doing a distal aortic stent alone?
Yeah, Vishal and Raman. Want to go?
Raman.
Yeah, I think it all just comes back down to exactly at what level is this aortoiliac occlusive disease, and
well, you got the angel right here, so I'm playing the angel.
Right.
I don't know if you can
in this particular scenario, I think I just hit the nail on the head. We do have enough of a distal landing zone above the bifurcation. So I think in this particular case, I think my first instinct would be to say, let's see if we can just do just a dedicated distal aorta graft, and that's it, without involving the actual iliacs. I think we have more than enough space. I think also, there's some disease that we see more distally in the external, but I think in this particular case, for her, less would be more. Fix this one nearly occlusive lesion in the distal aorta. I think that would be enough.
Right.
Now, as the disease goes a little bit more inferiorly, maybe not even truly involving the iliac arteries, but it's just more distally. I think even in those cases, you would still just preemptively plan to do a CRAB just to make sure that you've at least preserved both of your iliac limbs.
Right. I agree with Raman. That's what we were talking about. If you have to do an aortic body case, this is an ideal case. Below the IMA, below the renals, above the bifurcation, focal calcified lesion. So this will be like an ideal case for putting just a distal covered stent graft and hopefully getting away with it without involvement or any compromise of the iliac ostium. So I think here we did the IVUS, we did the angiogram, we did the CTA, and we know that the iliac essentially is not involved or pretty much normal. So it's safe to say that we could get away with just doing the stent graft here and covered stent, of course, in our experience, not trying to do be the old-fashioned way of just putting a bare metal stent.
Now, what about if, as far as the adjunctive therapy here, we were talking about doing the IVL in this case. Would you go up with 1 or 2?
Well, so nowadays the good thing is Shockwave, the IVL, they've come up with bigger sizes. They've come up with even an 8 and a 9.0 IVL. So, I mean, here we can see the lumen is very small and tight. So if you can use even an 8.0 IVL, that should have enough body for it to transmit all the echogenic forces and help in cracking of the calcium. So we could go, I don't know what the PK and Karthik have picked up for the IVLs, but I would probably go with at least an 8.0 IVL in this case. Try to plaque modify a little bit and then expand it, or we can do, crack and pave or pave and crack, depending on how comfortable you are, or after the IVL, how it looks.
Well, why don't you comment on that? It's a good question. How do you size the IVL and so on and so forth?
Yeah, I mean, I think in an ideal situation, you want to size it close to the vessel wall, so that way you're really getting good apposition to break up the calcium. But the downside, obviously, is that you're obviously putting more force on a stenotic aorta, and you could rupture it. So I'm personally very conservative for those sorts of things. So I think using a 7-8 is probably more than enough, because it's going to still hit that calcium.
Correct.
The other thing you saw in the IVUS, which is nice, is that the calcium wasn't. It was basically right at the kind of the inside of the lumen, so you're going to get apposition even with a smaller shockwave.
Right.
So yeah, I agree with you guys. I would go with like a 7 or 8, undersize it a little bit. I think it's still going to get the same effect.
Yeah, I think that's a very good point. So I mean, especially with shock.
I agree. I would not go with an 8. My idea is just to modify the plaque, go with a 7 or a 6, because it's so tight. It's probably a 7 better than a 6, and then go ahead and just do what I have to do. This is not about getting a perfect result with the IVL, but rather, can you zero both guys? I want to see 3 zeros, and then there you go, 3 zeros. So I want to go ahead and show you the gradient. This is aorta to left groin, or right? Yeah, aorta to left groin. Very, very tight lesion, so everybody can see how important it is. And now we're going to go ahead and
that could explain some symptoms.
Yeah,
so the question is, Ajit, are you okay with shockwave with a catheter next to it? Because that's what we're planning on doing. It's something I always wonder whether we should or shouldn't do. We could always take the catheter out, put a wire up, and then do it. Do you think that can have any sort of deleterious effect with the shockwave? I know it's not been studied like that. So that's my question.
I mean, in theory, I guess it could, because it could kind of block
the waves, right?
In theory, but I mean, it still should have a good effect, and especially since I would want to have a wire across this lesion on the other side just in case.
Right.
I think it's probably safer to just do it with the catheter. I don't think you're
going to always throw an 035 wire up and upgrade the sheet.
I don't think you're going to lose much.
Yeah. So for everyone, I think just a couple of housekeeping tips for those at home. I mean, Dr. Guja and I and Dr. Rao have decided we've got a 5/6 slender on the other side. We've got an 035 wire super core. We've also obviously got the Lunder twist that we need. We've got a 12 French sheath available. We've got the aortic occlusion balloon available. We've got everything available, because if this goes wrong, it's going to go wrong within a second. And, we need to be aware of this. We need to occlude the aorta with an aortic occlusion balloon. So I'm just reminding Dame that we got everything ready before we go up with the balloon, right? We got all our kit ready. So if that needs to happen, as you all know, they're just going to open everything, throw it on the table, and we're just going to work really fast. So
there's a question for Dr. Radha. So one of the viewers is asking, if in case you have to cover the IMA, do you preemptively start taking pictures of the SMA or the celiac plexus or other vessels to see if there's any collateral flow? Worst case, if the IMA is occluded, or you don't care about them?
No, I mean, that's a great question. I think you definitely, if you're going to if you have plans to cover the IMA, because in this case, we're going to cut it really close just because of length.
Right.
You want to make sure your SMA celiac are open and, that they're healthy.
Well,
So
that's where the CTA helps.
Right, exactly.
Maybe after we shockwave, since we'll make sure, and then we can talk a little bit about axial imaging, the value of axial imaging in these kind of aortic cases, so on and so forth. So just what I'm going to do is, me and Ricardo are going to go up with this balloon. We just put it on roadmap for now.
What size did you end
So
up
what
with?
balloon do we have now?
7.0.
It's a shock, 7 or shockwave.
Oh, excuse me.
Okay.
The old smoker's cough coming back.
Raman, would you go 7 or 8?
I think I would actually go 8 because we see that that approximately the diameters were. I mean, I don't know.
Ready?
I would say that, but in the moment, maybe I would.
No problem.
I fear just go
Yeah.
down one size.
Exactly.
And I think
That's the problem here. We're going to run the iliac. Again, the balloons are too long, so I'm probably going to push it into the aorta a little bit and shock the regular
Yeah, it's a
aorta.
60 balloon, so they come in only
There you
one
go.
size.
I'm going to do it right here. Is that okay with you guys? There's no choice, so
Yeah.
I mean, it's not going to
I think
touch
looks
anything
good.
approximately.
Exactly.
hopefully not.
Yeah, and I think
Yeah.
we're just doing a low pressure inflation, which
Yeah.
Well, we're just going
also
to two
reduces risk.
atmospheres here.
Yeah.
Balloon going up. Can you give me put me on coronary, guys? Coronary. So, Karthik, can you talk about the technique of shockwave, or Vishal, while we do this?
So basically, we're giving pulses to break the
Ready?
calcium, like eggshell calcifications, basically.
Shockwave going?
No, 4.
The white 4, 2. Start with 2.
It's-
It's already expanded.
Yeah, but that's what
So,
I'm saying.
and then we break the calcium, basically cracks in the calcium to give us a luminal gain. And then probably helps in basically lesion modification, helps in lesion expansion and stent placement. So, I mean, technically you want to keep it more in the center.
I want
That's
everybody to notice the EKG as he's Karthik is shocking. This is not VTAC. Go, ready, one more time. Okay.
Neither paste.
Good. And I mean, not ideally you want to keep the lesion right in the center of the balloon, Floro.
Uh-huh.
But again, here we have a some iliac disease. So I mean, the question I wanted to ask from the beginning was, the right iliac is a concern, right? Right iliac is diseased. I don't know how diseased it is based on at least the angios. At least the distal common or the proximal external looks pretty significant.
Yeah, that's what Raman was
walk
talking
it out.
about.
Yeah.
So my question was, why not consider CRAB and do it instead of doing? I mean, you can isolate the iliac. You can do an isolated stent of that right external, right common iliac to the ostium. I think you can nail the ostium, but keeping a small gap between the aortic stent and the iliac.
The DSA?
I don't know.
Why
I
not
think
just do a
it looks
CRAB?
more external, distal common and external
the
to me.
right
If I'm
common
not
is
wrong.
also involved, right?
Yeah, there's like, I would say maybe a 20%
Correct.
stenosis, 30.
Oh, yeah. I would not be
No.
Yeah.
Enough,
overtly
But
concerned.
external is
to-
definitely involved.
Yeah. But I think even in the scenario in which you do want to argue that there is let's just say that there is a significant lesion in the proximal right common, I think even if you do end up saying you're going to
Maintain
even
the
save a
arch.
gap, you would still have at least like 15 millimeters or so
Yeah,
by
that
the
should be
time
fine,
you're actually
yeah.
done
I
with
mean,
this.
yeah.
So even if you do
Ivis?
want to do your
Give me a
distal
wire.
your,
Yeah.
your distal cuff and then do a
Overlay.
proximal
This side, right?
stent for the CIA on the right. I think that would still be reasonable. But I think
Do you want to size it on
upgrading
the
the
sure.
entire procedure to
Carana.
CRAB may end up being
Yeah.
Do you have a,
a little bit more challenging. Plus,
29?
I'm sure there's a
I-
good chance this is
I
be
think
a
I think there's
return
no.
customer considering with the
Correct.
smoking and the
Yeah, it was small in this.
I don't think there's any reason for a CRAB here.
Yeah.
I
No, I
wouldn't-
agree. I mean-
I would not consider it. I think that this is a lesion, that's isolated to the aorta. The
One second.
the
We'll
no,
give
this
you
should
some
be
background.
overloaded.
Yeah, but
I
I
mean,
think
it
that's
just adds more complexity to it.
Intervention is also quite
Correct.
challenging.
Yeah, I mean, it adds more complexity. I mean, I think
Correct.
the more relevant question for Jit is if this, when would he choose an aortic stent graft in this case versus a VBX? I mean, are those days gone right now with the advent of larger VBXs?
Yeah.
Because
Well-
obviously, you could have in the old days before VBX, you probably would have done something different. right?
Yeah, I was thinking, so like the options, one of the other options that we used to do a lot is AFX. If we're going to use stent graft. The downside of that, especially for like PVD cases like this, is the sheet size. So the VBX, right, we're going to use like an 8 French
We are
sheath.
using an 8 French.
You need something much larger for an AFX, and so you don't always have that access option. So this is, and obviously these stents will track better and everything else. So I think especially with CRABs and things like that, fewer of us are doing AFX cases for occlusive disease at this point, because you can get really good results with the CRAB configuration.
So if you can focus back on the IVUS, guys.
Yeah, let's see that. I think the vessel size also favors the use of VBX in this case. It's not a huge distal aorta. It's like 1.2, which even if you use an 8 or 9 VBX, you can easily expand it to that length.
Yeah, that's a great point. Most stent grafts for when we're doing EVARs start around 23. So
correct.
That would be very oversized.
Okay, so I'm going to do pullback from proximal.
Shorten to 16.
Yes.
Bring down, please.
Lose how much again?
Again, 3.
Like 9.
Well, 3. Yeah.
If you 8
record.
8 to 16.
So just pulling back slowly.
So here you can see a little bit of that plaque right there.
No, it's still
it's
okay.
coming
That's
down.
okay.
Yeah, it's still distal.
Proximal.
Yeah.
That's still proximal, and now you're going to see it in a second.
Actually, it looks a lot better.
A little bit of luminal gain there.
The expansion was fine.
I jinxed us when I said that.
I think there's a little bit of recoil there. The calcium is
Okay,
broken.
let's do it one more time. We're going to measure now.
Yeah. I mean, there was, even objectively, there was a moderate increase in the distal pressures. I think it was from like 90s, maybe like 110s or so. So there is.
We're going to come down now.
I mean, and PK, like we talked about, the use of shockwave is not to really get luminal gain, but mainly increase the elasticity of the vessel. So now once you deploy the stents in, it doesn't act like a resistance and gives you more pliability.
I mean, the other interesting thing is that despite all this calcium that we saw on IVUS, when Dr. Goodrow was going up with the balloon,
that's the
even
lesion.
before the
firing of the
emission of the
distal,
sound waves, the balloon had already expanded.
Correct.
So perhaps this may, albeit there is some degree of calcium, but this semi-compliant balloon at even low pressure was able to fully expand.
So now this is a good question. Well, Dr. Gu just doing the measurements at the proximal, and then
I'm just doing distal also just to.
Yeah. So the question is,
I think distal more than proximal.
Why is CT or IVUS for sizing of the stent?
Yeah. So when we size stent grafts for AAAs, we often just base off on a CAT scan. I personally like IVUS. So when we do dissections, we use IVUS. I think it's great for sizing. I think you can see it in real time. CAT scan has its drawbacks, especially if the distally it's underfilled for a severe stenosis. So I think if you have any question about sizing, you should use an IVUS. So I think here it's a good option to use to really make sure we're picking the right stent, because you really want to size the VBX almost 1-to-1 with a native aorta to get the best results. So I would say IVUS.
Distally 10.
And so on the CAT scan, we're getting around 9 to 10, maybe around 11. And I think on the IVUS
I think
here,
11 too. Karthik is being a little bit more conservative on he's doing endoluminal.
Yeah, well, this is going to be the next question. You read my mind. How do you measure? Do you measure lumen to endoluminal, or do you measure from adventitia?
External, yeah, E to E, external.
Well, it's a big controversy because we went through it in Live BTK. That's why I'm asking.
Yeah, I think it also depends what you're seeing in between, right? So if it's a very calcified, stiff lesion, then I think if you size it for the inner diameter, it might be conservative. It might be a more conservative, safe approach because you're less likely to disrupt the wall.
Usually for aorta, they say usually
this I would say is somewhere in between. Yeah. I think we could probably do either way.
I like that, Raman. What do you think?
Yep, I like it.
Do we have 11 by 29? Yeah, and you can always okay. So, yeah. Let's see what it looks like here. Because the other thing is you don't want your stent to migrate, right? Especially now that we shockwaved it and opened up the lumen, we want to make sure it's still going to sit there, because you can always start with a small diameter stent and then, post dilate the VBX.
Correct. That's exactly what me and Raman were talking is you start with a smaller luminal VBX and expand it, because they can go all the way, 8 can go all the way up to 15, 16. But the downside is now you start shrinking the stent. So do you lose the length you want to lose? Are you comfortable? Do you have enough margin to lose it or not?
Here. All you need is a 20 length. So
so when we measured it on the CAT scan, a 10 by 29 was very cutting it very close. Anything longer and we'd cover, it would be too long. So
what did we decide?
So I think it still looks pretty narrow. So I think if we start with a 10 and then I really don't think we have to post dilate it, but we can always.
I don't either. We just need to get rid of the gradient.
So I think it's 10. What do you guys think?
That's true.
1029, guys.
Especially in these cases where the length is of concern, it's better to have a bigger size stent, so that way you shrink as least as possible and then still keep within your acceptable limits, right?
Yeah, especially right now, if access and sheath size is not a matter of concern,
Very
you
true.
have everything you need. There's no reason to not, to limit
Correct.
your armamentarium just because of,
injection.
just trying to avoid.
Very true.
Double injection, you can't do
Yeah.
it.
And I don't think it's going to foreshorten that much by just going
Correct.
1 millimeter over. So.
Exactly. No, 10 should be great. I mean, we're talking about initially
You go
8
from
and 8.
to, like an 8 to a 12 or something.
Then, of course, there's
You
a...
can't see proximal to it though. All right. Let's get the VBX up. This is the
So
035,
the other-
right? All right. So give me a 035 Supercore. We'll put it through the VBX and then we'll switch out. We'll take the sheet further up. I want to take a better picture proximal, and then I want to keep the. So this is an important technique. So what you want to do is you want to get the 8 French sheet to the ostium of the right common iliac. You want to do that over a dilated and 035 wire. So you can do it over an 018 wire if with a dilated, but I think with this situation where we're going to take the VBX, put it in place, we can walk the VBX out, and then you really want to. Can I have the VBX, please? Then you really want to do a picture to really see where you are in terms of your IMA. And obviously that's going to be an angiographic placement versus a, we don't have a CT or IVUS guidance. The advantage here with a radial would be good, but we did a radial diagnostic, so, we don't want to restrict the radial again. I mean, that's another pain in the neck. So I think what we do now is just please pull the wire.
Yep.
So we're just going to take the VBX, and then we're going to change out for an 035 wire. So the VBX is going nice and smooth.
Would you unsheath it if it doesn't
Yeah,
track? Is that kind
that's
of your
what I was
next
gonna
move?
ask.
That's my next move. I'm just gonna I think it'll track because everything went really smooth. See, it's already
Nice.
across. So pull out this wire, put an 035 wire up.
Dr. Christian, 10 is nominal, it'll be 10 at 13, it'll be 10.4, 8 to 16, it'll be 10.7.
I mean, the Gore fork may not like it because what I'm gonna do is I'm gonna walk the VBX out again, and obviously it's been wet and expanded, but I think it should be fine. I don't feel comfortable with this iliac to track this over the VBX using that as a dilator. So I'm gonna go ahead and I'm gonna walk this out. I'm gonna have Karthik just walk it out. Yeah, push it all the way up.
Now, what about the wire on the other side? Would you?
I'm probably gonna pull it, or you could leave it depending on what you want to do. But I think pulling it may not be a bad idea.
It's just an 014 wire.
Yeah, it's an 018.
018.
035.
Yeah, I think you can
please.
just keep it and pull it at the end once you deploy it before you post it.
Yeah.
Should be good.
I mean, I think part of the reason I felt that the VBX would go just make sure the VBX doesn't have clot on it, please,
yeah.
or any fabric.
I did.
on it or
I
anything.
already did.
Okay. No
So there's a
fabric on it.
10 VBX which is crimped on it, right? Crimped on the balloon.
Yes.
What do you mean crimped on the balloon? I didn't crimp it.
No. It's
No,
it
that's
comes
how-
as a.
it comes as a-
full stent,
Correct.
Hold on, I'm just gonna push this up a little further.
so that it doesn't need to be expanded. That's what Vishal is saying.
Okay, I'll fix the sheet right.
Yep.
So I'm gonna leave it right that spot. Hold it.
On the crumpled thin stent.
Okay, ready for picture now? Why is there no pressure? Give me pressure, guys. All right, good. Ready? I think this is.
We put the injector on that?
Go for it.
So Ajit, I'm just curious. Should we check a pressure gradient across the iliac after we're done in case we might have to fix it?
Yeah,
Or-
I think it's not a bad idea just to double check because we're probably going to check the pressure gradient for the aorta. Because the other interesting thing about this case is these are pretty uncommon lesions. Usually, if you have something like this, it extends into the iliacs. So having an isolated
Looks like we're
aortic.
having a really hard time filling it now. So I'm gonna go back, go
injector
further
on it?
in. Huh?
Yeah.
Can you put the injector?
So I think
Put
it's
the
worth
injector on
checking
this
because
side then. Yeah.
down the road this is going to need surveillance. The iliacs to make sure that this
Right.
doesn't progress. So
Okay, flush forward with
it's just
the
nice having
with
another
the-
objective measurement to know it's not
flush forward with
significant.
that,
But
and then
based
flush
on the
it.
angio, it doesn't look significant.
Flush the injector forward.
I think the ideal situation would have been we would have
Flush.
IVUS from the right side,
Yeah.
and then
Go
would
ahead,
have
flush.
seen both at the same time. Now we're still
Yeah.
debating about right is significant or not. But again,
Yeah.
pressure gradient is a good physiological marker at least. I mean, I know the IVUS might show more disease than what it looks like, but the pressure gradient
There
definitely
you
should
go.
be.
Yeah. But even the
Even then, you can't see the
that
IMA
small
though.
ischemic
You can
embolic
just-
issue was
Correct.
on the
Oh,
other
from
on the
the
left
right.
side
Very
anyway.
true.
So
You're not
even if you want
That's
to say that
reasonable.
this is,
We
she
do
probably just
picture
has
from
like
above, or-
ischemic rest pain, but
Try
I
to-
do not believe it is from
When
this
they're pushing
little
it.
external
Now
issue.
let's
I
try.
agree.
Yeah.
Yeah.
roadmap.
You still have to visualize the IMA, right? Because
Although
that's what we're trying to do.
as he did advance the sheath over, there is a small gradient, maybe 5 or 10
Yeah.
cross-side of the iliac. I think that's
That should be
reasonable
okay,
to
yeah.
leave that one alone.
Jeez,
Wow.
this is really becoming a painful thing for me. All right.
Just put the catheter from this side.
But again,
you can
just to
always pull it
clarify,
Ibrahim
the
was
S
right to get a left radial access. Well, the
That's
left
what I'm
radial
gonna
is
do,
close.
yeah, once you have it, you can always pull
Oh,
it
yeah.
down, right?
but just to clarify, the SMA and celiac are open, so you
What do you
know
need?
there's enough
Yeah.
collateral
UF
probably through the
catheter.
UF
IMA.
catheter.
So
Yeah.
So we're gonna go with the UF catheter. We're gonna pull it out as soon as when we're ready
And-
to
Yeah, that's
expand
probably
because I
better,
really
right?
need to see. I think when we go with the stent. So
and both hypogastrics
and
are open
both-
too.
Yeah.
So we're just gonna take a picture and take the UF.
Yeah, I
catheter
think
out.
it's. I mean, that's the right thing to do. It's very important in this case to visualize all your IMA specifically. You also have two lumbars coming just above the IMA as well. So in order for PK to
Real?
place it accurately, it's good to visualize. So he has to go through the left side and put a
Okay,
picture.
pull the wire out. Okay. So we're just gonna
Right here.
wrap up. Ready?
Doesn't look right. One sec. One sec.
Wait. Yeah.
What happened?
Flora,
It's,
No, it's stuck onto the
it's on
wall.
the SMA.
It's on
But it's a pigtail catheter,
No,
guys. Not an endo catheter.
I know, but it comes through the end hole too. So
Not really. Come on. I don't know, man. Sometimes I worry about all of you. Ready, Flora?
That's where all the dye went, PK. See?
Yeah, all the dye went out through the end hole. I think Karthik needs to eat breakfast. Ready for it? I'm joking. All right, there you go.
There we go.
All right.
Beautiful.
Yeah.
Finally.
You guys are so
All right,
No more
wire again on
pictures.
this side,
you
guys.
guys are horrible. That's
I know
what
we
you
got to
guys
pick on you. Wire again on this side. So we're gonna put this wire up and just pull out the
No,
pigtail
I
and then
don't want
go.
to put the wire. Why do you want to leave the wire?
Why do you want to leave?
take
it?
But
it
We're not
even
gonna
though these
stent
are
with
rare
the pigtail,
lesions,
right?
and I don't
Just
think there's
pull the
much
catheter
data
down.
on
No, but
just
not with the
isolated
lesion,
aortic
especially
stenosis
with
compared to other
emboli, right?
areas. I would imagine that this would do pretty well over time. I think what
Yeah.
would cause it to fail over time would be progression of iliac disease, would be my guess.
Yeah, I think you're right, Ajit. I mean, surveillance of the iliacs will become the primary investigation once this aortic lesion is
Perfect.
taken care
Let's
of.
give us
so.
the stent now on this side. So we just pulled out the pigtail type catheter on the other side. We're going back with the VBX on this side, and then now we can visualize everything. We're just going to go up.
Yeah. And then I think the other important thing is how much seal you need on either end. So this is a very focal lesion. So thankfully we can use a short stent graft, but trying to get around a centimeter above and below if you can without compromising anything I would say is ideal.
Yeah.
So we're going to be, have just enough with this.
Okay. So now obviously we're going to work off this roadmap, guys. That's the situation we're in. So
Is there any way to see the iliac bifurcation a little bit better?
Yeah, I can
inject
walk-
from. We can
I
inject
see
from below.
above,
No, we
below.
can inject from below.
No, but
I
then
just
you
wanna
lose the
make
roadmap.
no pressure. You're going to inject from here. You can inject from here. You have flush sword?
Because I would say obviously nailing the
We can't
bottom, I
inject
would
from
say
there, okay?
is because we can't
More
drill out the
essential.
other
Yeah,
side.
Can't inject from
So
this
Correct.
that's the one we need to
Or short
really
sheet.
nail, and then we save the IMA, we
Or
save
short.
it. But
Mhm.
this is also the shortest VBX that we have.
Short
So
sheath.
Correct.
it's a 29.
So you want to take a shot from below now?
Yeah, I just want to see that.
Yeah, good pressure you
Yeah,
are?
the iliac. Maybe just a touch.
Huh? Okay. Uh-huh.
Sheath, how is it going to go? How are you going to see it from below? It's a short sheath.
Try again. Full inject.
How are you going to
I
see
don't
it?
think
I'm
it's.
not going to be able to see it. But I don't think you're going to be able to inject through here.
You can. Why not?
Your leg hurts? Okay.
It's the contrast.
The contrast.
I think it's okay.
So give us a pigtail again through this, guys. We'll go through this. Yep, push
It's on the
forward.
wire.
We'll just land it distal. We'll pull the wire out, and then we're just going to have to go forward and then look at it again.
Keep going. Keep going.
Okay, pull the wire out and do another picture now. Then we'll just have to walk the pigtail out again.
247 ACT. We're fine with that?
Huh?
247 ACT.
That's perfect for now. Ready?
Maybe.
Maybe a little bit higher.
No,
Yeah,
maybe a
push it.
touch in.
That's what I'm
Yeah, I
saying.
think we have to go higher.
Yeah, you have
Just
to
to
go a
be
little.
safe.
Oh,
We're
too
gonna lose
much.
them anyway.
Oh, we'll take another picture here.
I don't think so.
That's
It's
perfect.
good.
I think
It
that's
looks
good,
good
huh?
to me. Yeah,
Let me
it
see
looks
where
good.
the top is.
Looks good to me. It's going to
I think
fall
it's
fine.
good.
It's fine, no?
Yeah,
SMA is right above it.
It's
Yeah, I think so. I mean, we can
Minus
bring it down maybe a millimeter, like just a touch, but then that's it.
I think the IMA
But
still will remain open. Yeah.
Yeah. Well,
Because the stent is between the
perfect.
dots, is not on the dot. So we still have a touch room to really go in.
all right, I'm happy with that. What do you
All
guys
I think
think?
that's good.
Walk this out over a wire now. I'm just going to fix this.
Why don't you roadmap this, Mika, before you walk it over?
Yeah, just roadmap this one more time,
Okay,
PK.
go ahead.
Oh, I unplugged it. Wait, I unplugged it.
Oh. Go for it.
Withdraw.
But this is a
Yeah, I think it's
nasty
very
looking.
important for I think it's very important for the audience to realize how important it is to really nail the stent in this case. So even if you might have to go back in like PK did almost 3 times getting the pigtail up, it's worth every effort, especially when you're trying to not compromise your iliacs. Like Ajit talked about IMA, if you compromise a little bit, that's fine because the SMA and the celiac is open, but definitely you don't want to cause any trauma or any anatomical disturbance to the iliacs because then you'll get up in big trouble. So especially being a covered stent. So I think that's very important here.
Doing this particular
okay with it
procedure
now? We're gonna
correctly
go up.
will actually dictate
Attach?
the ease of subsequent procedures.
Correct. That's absolutely true.
You happy with that, guys? I'm
Yes.
pretty good.
Mm-hmm.
Yeah, just
Slightly
Looks
back.
good.
slightly.
Slightly
Yeah,
Slightly
just
back or down.
Oh.
yeah,
That's good.
yeah, perfect.
That's good spot.
Perfect.
That's it.
Okay, let's go up.
Keep backward.
10 sounds good.
I don't think you have anything open up with the pressure, by the way, guys.
Yeah, that's okay. Right now we're not going to have much pressure anyway.
Wow, look at the lesion, how tight it is. I mean, I know you're going slow, but that's good.
Slowly.
Go to 8.
Keep
And
going.
down. 8 and down. Just go
What
down.
is it? 10 is nominal?
It's off on the other side now.
9. Go to 10. Okay, down.
It's well expanded.
Mm-hmm.
Down.
Yeah, that opened up
It's back,
nicely.
Mika.
Yeah.
Sheet back. Walk the sheet back. Walk the sheet back.
Don't worry.
Don't keep it so close to the stent.
Go up again.
You pulled the balloon up or?
No.
Just inflating again?
Yeah, it's just
Pull
close
this
to
wire
it.
out.
Down.
Okay, I'm going to pull this wire out.
Yeah, we're going to pull the wire out now. The other wire
I'll
out.
rewire it once the balloon.
The pressure is on with the balloon side, so you won't see a pressure, unfortunately.
Yeah.
No, I see it.
Yeah, pressure is back up to normal now.
Wow.
Nice.
Okay,
Very nice.
let's just wire this up.
Yeah,
Let's walk
just-
this balloon back. Walk the balloon back a little bit into my sheet now. The balloon. Walk the balloon back. Okay, well, let's push the wire up on this side.
Very nice.
Push
Did it
it
pop
up.
through? Yeah.
Yeah, definitely.
Okay,
Take
now
your
put the
pigtail
pigtail up.
up. Watch it. Okay, be careful.
Okay. Let's detach this. Flush forward. Okay, ready for DSA, guys? Ready?
Wow.
You have to prime it.
A lot of saline. We'll do it again.
Oh, opened up nicely.
The IMA.
Perfect.
The IMA is there too.
Okay.
Yeah. I mean, I think that looks
Very
great. It opened up nicely. I think our distance above and below is good.
Yeah.
Now let's see the gradients. Aorta to right. Flush forward, guys, the right.
Even if
You
it,
would
I mean, I
have
think
to
it
follow
opened up all the way, but even if there was a little waste, 10%,
Leave
20%,
it.
if there's no gradient, I would leave it.
What gradient is acceptable for you? Flush forward, Karthik, with this?
Uh,
I'd leave a 5mm gradient. It wouldn't bother me. 10mm, it wouldn't bother me.
yeah, I think
Yeah.
that's,
10 is the.
that'll be enough to,
So let's
Heal
zero
the
both.
The problem is
guys.
that
No
it's
gradient,
always
no
going to be
Zero
12.
both. Zero both.
What about 13?
Zero both.
It's like, well, that'll be a problem everywhere. You do coordinate stuff, FFR, it's 0.8 to 0.9. What is it, 0.9 but not 0.89? I don't know. It's always a tricky game. But I think in this case, it
really good,
looks
No,
nearly
can we-
resolved.
Can both read 0, 0,
Yeah.
0 for
Yeah,
me?
both are.
the other nice thing is we leave options open in the future. You know, we could still
Correct.
convert this into CRAB down the road if there was
Yeah,
any
exactly,
progression
yeah.
of disease. So
Yeah.
this is a nice way to do it.
0, 0, 0.
Yeah, it's 0.
If you pull the your
Yep.
right sheath back even a little bit more, you can account for whatever is
Whatever the
involving this
lesion is
common
there.
iliac
Yeah.
disease.
Yeah.
That's even that even before it looked like
Okay.
it was just like 5 or 10.
But I think that's why
All right, let's go now to the gradients.
also like sizing I think is really important because like the
No
CAT
gradient.
scan IVUS we used a 10 based on that. But like if looking at this angio, I would have thought it's larger, but it's
Oh,
not.
that's nice. The same 5, 6, 7, 5, 6, 7.
Iliac is nothing.
Nothing.
All right, I'm going to pull the right sheet back now. No gradient.
More.
Beautiful.
Yeah. There's a little something in the external,
Yeah,
but
yeah.
I think it's good. It's very acceptable.
even that is exactly what it is. It's a little
10
something.
millimeter.
Yeah.
Little something. 8
A
millimeter,
little
10
something.
millimeter.
8 millimeter. Good.
All right, let's do 20, 40, 1100 PSI.
20, 40.
Jesus.
He likes.
Maybe that's too much.
The sale,
Too much.
That's Reno.
the sale on ISOView,
I know.
Reno.
How about a nice 10, 20,
2040
15,
right at the level of the renals.
No, there is a
20,
good
40, the whole
20
body
millimeter
goes
gradient.
glows.
No, yeah, no, 13 millimeter gradient,
Ah, 12 or 13.
right?
There it is,
Exactly
Raman.
what it is.
That's Dr. Sharma's fault.
0 again. Flush the catheters and then take it one more time.
Well, I mean, we're here, right? So we do. Okay.
No, I know. Jokes aside, you're right.
I mean, we'll decide together after this picture.
I don't know.
I don't know.
I think we'll leave it.
I could believe the fact that she would become symptomatic still after just a 10, 12 and a half or so millimeter
I
gradient.
mean, it was 80 millimeters before.
Yeah. It was
You know,
more,
Oh,
I
but you
think
can
it was almost
clinically,
like
I mean, I don't know.
90 or so,
Yeah, you can clinically follow her and see if,
Yeah.
like Ajit told, worst
would
case,
believe
if you
I
have to
believe
do it.
too. Making it very
just leave it.
complicated for no reason.
We're talking about.
Yeah.
I'm talking about the
The
gradient
aorta?
on the right, which is only 10 millimeters, right?
I think I would.
I think it's that
I would
iliac,
leave it.
because this side
Angiographically,
is-
it doesn't look
this
bad
side
at
is
all.
equalizing to
So
this sheet. I think it's probably the iliac.
I'm not
Okay.
convinced.
I
You know,
don't
I think
think
this
it's
is
the
enough
aorta.
to.
I think it's the
heal a
iliac,
wound.
not the aorta. So
No, it's not the aorta. I'm talking about
No,
the
no,
aorta.
yeah,
I
yeah,
don't
yeah,
know.
yeah.
I think
No,
I
we're
would
talking
Oh,
leave
it's
it.
definitely not there. It's definitely not the
I would
aorta.
leave the
I think I agree. I think we survey and we need to convert to put VBX through this in the future to make it normal. I think we do it, but I think we're done. So
Now,
anyway,
a
so-
question. Now
Uh-huh.
let's just say that we do in the future, in the next year, 2 years, you had some progression of that common iliac. Would your approach be to fix this? Would be then to do a CRAB, so as not to leave just a like a 15
Yeah.
millimeters of healthy distal aorta, or you think you would be able to get away with just a
I-
dedicated iliac stent?
I cannot imagine that this lady is going to get she's going to get symptomatic with this. I cannot.
Well,
10
let's
millimeter
say she.
No, it's just like
let's say she picks up
What are we doing
smoking
here?
for
I'm just willing to
Christmas.
see the external iliac.
She smokes every day.
I mean, it's a good point.
I
I mean,
would-
in CRAB, the problem is we don't have an
Injection both.
Corona. We have a new Corona.
and
We can't go
below.
up and over. If we treat it like how we treat a regular right common iliacs, and if it's just at the
are we
ostomy,
doing
park
here?
it there, we can suffice
is he
both
doing?
purposes.
He's asking
If there's
here,
no
he's
distal
asking
aorta disease extending into the
Yeah.
common
What are you
iliac.
guys doing?
So probably I would do is again re-IVUS
what are
all
you
the way
doing?
from my stent graft into the common. See if there's not much disease, then just treat it healthy and then go.
Yeah. Ideally, we don't like to
Yeah.
keep like a very small gap.
Correct.
I think in this case, I would still do the same thing.
I agree.
Okay. All right. Our
Awesome.
last
Call it
picture
a day.
here, guys. We're going to inject from above and below. We're going to inject from above. Then Dr. Guja is going to inject from the right iliac, I believe, or left iliac. It doesn't matter. Ready? Inject above first.
Wow,
Ah,
gorgeous.
beautiful.
I think we're done.
We're done.
I think it's
Yeah,
good.
Definitely we're done.
Nice job.
Yeah.
So, Ajit, couple of questions. When do you choose to do axial imaging? Let's do a full runoff to the foot.
For her, as long as she does well, I think 1 month you could get a CAT scan.
And
Just-
how do you follow her?
and then after that, as long as you have a good vascular lab, I think you
Just
could do
take one picture from the
ultrasounds
aorta and do a run.
and clinical exam.
Don't have to do any more.
And then, like ultrasound ABIs.
We can cover both.
But I would start out with
cover
1
both.
month, 6
cover
month
both.
follow up after that if she's doing well, and then
Do the
kind of
other
go
one.
from there.
Yeah, both in one. Yeah, flip it. Flip it.
That looks good.
But I think if you do ultrasounds, because
You can do
aortic
both legs and
ultrasounds
just
are
do a
obviously a
runoff.
little bit harder, so you need a good ultrasound tech
Do a
and a good
coronary.
lab.
Yeah.
So you can certainly do it, but you have to make sure you have someone that you can trust.
It's funny because the gradient seems to be
But-
getting worse.
I think it's
Just
just the contrast. If you flush the catheter and we just do a zero
Yes, that
again.
makes sense.
That's 0 again.
And flush the sheath.
But
So
I would
flush the
definitely,
sheets first.
I would definitely get a CAT scan though, because
Stanley?
this lesion was very calcified, eccentric, and
Stanley, flush
you know,
that.
so I would say you need at least one good CAT scan.
Mhm.
Is that what you guys do as well?
Yeah.
Mhm.
Imaging at 1 month?
Imaging at 1 for sure.
There's zero both
Probably
guys.
repeat at 6 months and see how she's doing, unless symptoms change earlier.
Yeah.
I mean, it's
I mean,
it keeps,
she also
keeps-
she also could just have some other de novo iliac
Correct.
disease. That people can have iliac disease without being symptomatic from it.
I agree.
You know.
Oh, that's what you were doing. I didn't understand what you were doing. Now I got you. Makes sense.
He's a graduating endovascular fellow.
Hey, zeroing both. And
Finally, Ibrahim had the guts to say something. Good, Ibrahim.
did you give hydralazine, Liz? You don't need any.
There is some gradient.
See, there is a good gradient. And this is left leg, right?
No. This
That's
is
the
right leg.
aorta.
I think it's
The
just the
aorta.
external.
Right leg to the aorta.
Yeah, I think it's.
Oh, that's right.
external.
Like,
Left leg.
do we measure the left leg?
I'll do that now.
Because the left leg is the one that had that discoloration.
Yeah.
So,
Flush forward.
because the right leg was more claudication, right? So we fixed one level. So I think this would definitely
Flush.
improve her symptoms.
Yeah.
Mm-hmm. Flush into the aorta now, into the sheath. Okay. And now left leg. Zero both, please. Ah, don't move, mama. Zero both again.
Vishal is going to go home today and keep saying 0, 0, 0.
I'm just helping you, my friend.
3 zeros, please. There you go. Thank you. Yep, same. So it's an aortic issue. It's not
It's
an
an
iliac
aortic
issue.
problem.
So we're done. We're not fixing the aorta anymore. We're done. Agreed?
Yeah, I think we got a good
Yeah, I
result.
think it's fine.
Mm-hmm.
All right, let's just do the runoff here for us.
Want to just shoot from above? Shoot from
Oh, you just want to do a regular runoff? Yeah.
no.
Ready? Just
Yeah.
All you do
non-DSA?
is
Yeah,
put
it's on
both
non-DSA.
sheets and just do sheet pressures. Forget the distal aorta pressure.
Why not?
Yeah, exactly. Yeah.
Or definitely 100%.
Cine.
Cindy? Inject. Okay, let's do DSA here.
Very nice.
DSA. Inject.
It's quite a good result.
Yeah.
But
Pretty much what she had before. All right.
Yeah.
So we're just going to do a quick IVUS now. Can I have an IVUS catheter? 035, 018 wire.
Yeah, PK, if you want to make it more interesting, what you could do is get 2 sheath pressures only.
Oh my goodness, you
Oh my
will
goodness.
really want to push the
all
pressure.
right, too much pressure.
I mean, I'm just
much
trying to help
pressure.
you. Too much pressure, but
I
what do you
told
want
you
to do?
already. He's going to go. It's a 0-0 today.
And he's going to go home and say 0-0.
But I think that was very important shooting the runoff because especially for iliac cases,
Embolic.
sometimes we don't do that, but you could easily get burned by getting some, piece of clot that travels down or plaque into the pop and you don't know until afterwards.
Exactly.
So-
I think it's a good discipline for all of us to do. And so now we're going to do a quick IVUS. And what are you looking for in this IVUS, Ajit?
So I think the stent opened up well, but we'll check with IVUS. But really what I'm looking at is the endpoints. I want to make sure it looks healthy. It doesn't look like we
Opposition is
disrupted
fine.
anything. And that our stent's well opposed. Those are the issues, especially since, we're talking about the pressures. I think the IVUS will reassure us that we got a good result with the stent that we placed.
I gave already.
But yeah, endpoints are key, I think, here.
On that side, on this side only.
Okay,
Yeah.
proximal.
So
Okay, record.
so far so good. Still above our stent. I think we're coming into the stent now,
Yeah,
which looks
there,
good. I didn't see
right
any
there.
severe stenosis, so that looks pretty well posed.
Well expanded.
It's pretty well expanded.
Yeah.
Actually, very well expanded. Uniform.
And distal. That's it.
That's it. So yeah, it looks good.
Yeah.
I don't see any areas of concern.
Yeah.
Perfect. So we're
Perfect.
done.
The iliac
So,
looks
so
okay too.
Yeah.
anticoagulation wise, what do you do?
You can take it on.
I think, if she has
Why?
good pulses, I would
He's
probably just do an
Oh,
aspirin.
yeah.
Yeah. why don't you go on?
I'm not sure I put her on more than just an antiplatelet.
And as far as the toe and the embolism to the toe, obviously looks like embolic disease more than anything. What?
Yeah, I would monitor it for now. Hopefully, next couple of weeks it will start to improve now that we've fixed her circulation. But I would say it's not frank. She doesn't need like an amputation or anything like that. Just observation.
Perfect. All right, guys. Any questions? Any comments, Vishal and Raman? Anything?
No, it's a great case today.
That was good.
It was a very good case.
Yeah,
I mean,
excellent.
We've been focusing a lot on the aorta, and I think it's good because we didn't do a lot of aorta in the past. And I think, especially atherosclerotic disease, we did aneurysmal disease, and now we're doing this. So I think it's very good. And I think for next month, obviously, we'll have to come up with another case. So thanks again, Dr. Rao, for your time.
Thank you.
Dr. Guja, for your time. Thank you, Ibrahim. Great presentation. Ray, for being here. And Liz, for taking care of the patient. Thank you. Thank you. We'll see. Okay, Vishal, we'll sign off from here. We'll see you soon.